So we were quite encouraged by this. However, it's very difficult to apply a mass of bone cells in fibrin glue onto the surface of the prosthesis. So we used a spraying technique where we sprayed these cells onto the surface in fibrin glue. And again, we wanted to check that spraying didn't affect the proliferation and viability of these cells. And you can see that compared to control cells, the viability is good. And you can see that compared to control cells, you get a reduction in proliferation initially after spraying these cells, but with time this proliferation goes back to the normal levels. We then used a larger animal model, and this animal model was a mid-shaft tibial replacement in a sheep where we removed 5 centimetres of bone and replaced it with an implant which had 2 of these hydroxyapatite coated collars, which were either coated with fibrin glue alone or with fibrin glue and mesenchymal stem cells. This is the data, radiographic data. You can see at 6 months there's about 100% increase in bone formation around these hydroxyapatite collars in those cases that were given stem cells. And this is borne out by a calculation of the bone area around the implants from histological assessments. And you can see that if you increase the number of stem cells, you can indeed increase the response, although this does not seem to be a linear response. Importantly as well, when we used stem cells, we saw good integration of the HA collar with the surrounding bone. And so we then suggested that this may be applied to total hip replacements. Now, total hip replacements are very, very successful. And in the UK, the number of revision total hip replacements is around 9,000 as opposed to 50,000 primary operations. This accounts for 18%. The survivorship of revision operations are inferior to primary total hip replacements. And the NHS spends about £59 million on revision operations. And the main reason for revision operations is loosening. And here you can see a primary hip replacement which has become loose. And you can see osteolysis of the bone, which creates this loosening. So when a revision takes place, you have to somehow encourage bone formation within these osteolytic regions. So in this experiment, we coated the surface of an acetabular cup. Again, it was an acetabular cup in a goat animal model, and impacted that in place. And after 6 months, looked at the amount of fibrous tissue adjacent to that acetabular cup. Obviously, you don't want fibrous tissue. More fibrous tissue is bad, less fibrous tissue is good, and this red line shows that there is less fibrous tissue around the cups with stem cells. So it works, and we are applying for money at the moment to try and take this into the human. Orthopedic surgeons also use a technique called impaction allografting. And what orthopedic surgeons do is that when they remove the prosthesis, they are faced with very large, sometimes very large lytic cavities in the surrounding bone. They fill this up with bone graft. This is allograft, morselized allograft, and then impact that allograft very hard onto the existing host bone. And then they insert another prosthesis, and with time they expect that allograft to be remodeled and to be incorporated into host bone. So we were interested in sort of augmenting the allograft with mesenchymal stem cells. One of the things that these surgeons do is that they hit the allograft with considerable force during the surgical procedure. So, for example, 30 kilonewtons is about 9 times the force that you would use when you actually heel strike during a normal gait cycle. So again, we wanted to check that these stem cells were immune to this impaction force. So we suspension seeded these cells onto allograft. We grew them in culture for a 4-day period. We analysed their proliferation rate after impaction with various loads which relate to this 30 kilonewton load which surgeons hit the graft with. And what you see is that at the higher loads there is a decrease in the proliferation, but at the lower loads these cells are able to survive within the graft. So again we used an animal model where we incorporated stem cells into the allograft and compared that to animals where stem cells were not incorporated into the allograft. And we performed an impaction grafting operation. We analysed the function by measuring the hip joint ground reaction force, and we looked at the histology after 6 months. So this is what we do. We grow the stem cells up, we take these stem cells, we mix it with the allograft, we have exposed the femoral shaft, and we impact that allograft onto the walls of this shaft before inserting a prosthesis. And this is the functional data measured at 12 weeks, looking at the force passing through the operating leg. And you can see that there's a significant difference between control, allograft only, and allograft with mesenchymal stem cells. And that implies that this group is recovering faster than this group. And again, this data is borne out by the new bone area surrounding these implants. And what you see is that there's a significant difference in the amount of bone adjacent to these implants with mesenchymal stem cells than just with the allograft alone. And finally, and importantly, you also see that mesenchymal stem cells incorporated within the allograft enhances bone integration of the implant. And again, we are applying for money from the UK Stem Cell Foundation to actually carry out a clinical trial on patients requiring vision operations in Istanbul at the Royal National Orthopaedic Hospital. So, spraying MSCs in fibrin glue onto implant surfaces increases bone formation adjacent to the implant and improves bone contact. And it's been shown that this can enhance the regeneration